Well, hello. Good afternoon, and welcome to Recent Advances in Cancer Care, New Paradigms, Novel Agents, and What It Means for the Oncology Nurse for Patients with Relapsed and Refractory Multiple Myeloma. So I'm Natalie Callander from the University of Wisconsin, and just let me say what a delight it is to be here in San Antonio. I lived here for 13 years. I was stationed in the Air Force. I worked at Wolford Hall Medical Center when it still existed, UTHSCS and SA, and so it's just a delight, and go Spurs. So now I would like to introduce the rest of our faculty here. We have Beth Faiman from the University from Cleveland, Then we have Mary Steinbach from the University of Utah, Huntsman Cancer Center, and finally Hans Lee from Nashville, the Sarah Cannon Cancer Center. These are our disclosures. We'll just go through for all of our discussants. And we'd like to thank our support here today. This is an educational activity. We are going to talk about non-FDA approved use of agents. Now, what we're going to try to do here is break down some of the newer agents for relapsed and refractory myeloma, and in particular, we'll talk about just some of the graphs that show us how patients are doing in terms of survival. But we really want to be able to tell you the key take-home messages of how is this important to patients. So let's get started. So we'll do a general discussion talking about what happens when people have relapsed myeloma, and then we're going to talk about CAR-T, complications of CAR-T. We're going to talk about bispecific antibodies and those complications. And then we're going to talk about Belantamab. That may be an unfamiliar compound for you. And finally, we're going to talk about cell mods if we have enough time. So we all here have had many opportunities. I think this is both a double-edged sword. Now, people with myeloma live so much longer than they used to. Average survival in 2000, 3 years. And so now we see people many years beyond that, 10, 15, 20 in all of our clinics. So how do you go about when you have a patient with relapsed myeloma? What do you say to them?
I'll go.
Okay.
I don't like silence. So I think first of all, it's a very big shock because they were hoping that they were the one that was going to stay in remission for a long time. But we take into account the fact that they have lots of therapies available, the timing of the relapse, the aggressiveness of the relapse, and what the patient's preference are. So we have that conversation as we're seeing the slow biochemical relapse, hopefully, and we can reassure them that we have effective therapies.
Yeah, I'd just like to add, especially it's very disappointing to patients when they relapse, for instance, after a frontline therapy. I tell patients that this is not the end of the road. This is very much the beginning. And since we do have so many new therapies for myeloma that are very effective, we can really tailor treatments to patients' preferences that are very effective, that can really maintain quality of life.
Yeah, I agree. And when you introduce kind of what the whole plan is going to be over multiple years, I think that helps patients kind of grasp that this time will come, and at relapse they don't need to be devastated. There's lots of new therapies.
Yeah. Well, I think one thing that's happening for all of us more commonly and for patients is that many times now we're not seeing patients who are symptomatic at the time of relapse. They have what we call biochemical progression, where their labs are showing their myeloma is getting worse, but they may feel fine. And that's often a difficult conversation to somebody who feels they've been doing great to say, we're going to have to probably change gears.
Yeah, I agree.
Yeah.
Absolutely.
Okay. All right. Well, then I think what we're going to do is move on to talk about CAR-T here. All right. So I'm sure everybody has heard at this meeting lots and lots about CAR-T. So just for the basics, we're going to be seeing more of these as time goes on. And the reason is that they are a fantastic way of targeting cancer cells. Now, one of the things that you need for a chimeric antigen receptor T-cell therapy to work is a target. And we are actually fortunate in myeloma that we have some very good ones. But what you want to have is that target is something that the tumor cell needs to grow. It's nothing that is sort of frivolous, if you will. And secondly, you would like that target to be expressed on a high percentage, if not all, of the tumor cells. And thirdly, the ideal target is something that's not expressed on normal cells, so there won't be any sort of off-target effects, as we call it. Now, that's why B-cell maturation antigen, or BCMA, has been so widely seized upon in myeloma, because it's essential for the growth of a myeloma cell. It keeps it alive. It helps it make antibodies. And we do know also that as people move through even MGUS to smoldering myeloma to actual myeloma, the amount of BCMA on the cells increases, and so that just makes it an ideal target. Now, the first CAR T that was FDA approved, what I'd like to call the OG, is idacabtagene vaclusol. And this, again, it's important to put this in perspective. So it was 2021 when the first CAR T was approved. And at that point, these individuals on this particular study of about 125 patients, they had no other options. There was nothing left in the barrel for them. And that's why these responses, 81% of patients getting the highest CAR T dose responding and nearly half going in remission, was just so mind-blowing because we never had anything like that. And there were some toxicities that Beth is going to talk to us about, but suffice it to say, this was really earth-shattering for us and certainly for patients, particularly because of the ability to be off therapy for a period of time. And then ciltacabtagene autoleucel came out very soon after this. Same kind of design. These patients weren't quite as relapsed, quite as refractory as what you saw in the KarMMa study, but this is what I think captured everybody's attention. So if you look at that total response rate on the left, it's 98%, or 95%, I should say. And most of those individuals are actually going into remission. And then if you look at that progression-free survival on the right, how long does it take before they might need treatment again? It was on average 3 years, which is astounding. There's really nothing close to that. And probably the biggest news last year at ASCO was there was an update there that of these original 100 patients, about a third of them still after 5 years hadn't needed any more treatment, which was really amazing. So that there's no wonder then that CAR T has been moved up in line. So now ide-cel is approved after 2 lines of therapy, and this is based on the KarMMa-3 study showing a big advantage over just regular types of therapy if you had relapsed disease. And these are patients, again, who had a proteasome inhibitor, a IMiD drug, and an anti-CD38 drug outperformed those. And similarly, CARTITUDE-4 for people who had had at least 1 line of therapy. Most of these individuals had had a stem cell transplant and then had been on lenalidomide maintenance, but just outstanding responses in terms of time to next treatment. And in this case, they even had survival benefit that you can see below. So this is one of the reasons why the FDA also approved this for second-line therapy. Now, there is some safety issues, and Beth is going to talk to us about them. There is a newer product that is under development called anito-cel. It also targets BCMA. What the hope is based on some of the preliminary data, looks like the response rate, if you can see on the left, that huge response rate looks great. And what we're hoping is there's not going to be neurotoxicity to the same degree as some of these earlier products. And then in terms of the future, there are other myeloma targets that are being developed. This is for GPRC5D. And this is a protein that is on myeloma cells. It's also on a few other targets. But suffice it to say, this study, the quintessential study, is looking at people who've actually had one therapy, many therapies before, and in some cases, a BCMA-targeted CAR T. Looks like the response rates are very high, so we're going to see if this really comes to fruition. And then there are these dual-targeted CAR Ts that are coming. This happens to be AZD0120. This targets CD19, which is another receptor on myeloma cells, as well as BCMA. And the hope is if you have 2 targets, you can either hit myeloma cells who have one or the other, or you can more closely hit those that have 2. And this is also a fast manufacturing CAR T. As you may know, it takes maybe a month to get the commercial products. Okay, so let's move on to a case, and I want to just talk about this on a very personal level. This particular individual, you can see here, she's 58 now. She was diagnosed back in 2013 when she was 45. And this particular patient had high BMI, about 42, and she had come in with knee pain. And she had come in over and over and over again, and as you can expect, they had said, you need to lose weight. That's the problem. And she finally got a physician, this is months into it, who took a picture of her knee and said, oh my goodness, you have lytic lesions everywhere in your distal femur. So she got diagnosed, she had been on treatment, and as you can see in that long list there, she was basically on some sort of therapy between 2013 and 2022. And she had come to me and she said, I'm exhausted. I'm grateful I'm alive, but I got a wedding coming up for one of my kids. I need to do something different. And so this was back in 2022. Ide-cel was at that point had been approved for a while. We had access to it. The nice part of this story is this patient is still in remission 4 years later and living her life and doing great. And so that's the kind of impact CAR T can have. I wish in every patient, but in many, 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 I'm sure you've heard the similar story. So I'm going to stop there and start asking the panel some questions here. So how do you guys, how do you pick a patient for CAR T?
I can go because I'm right next to the moderator. First of all, I would like to thank you for highlighting that it was an Ide-cel case study because we do see successes with Ide-cel, but we have 2 FDA-approved CAR T-cell products, Ide-cel and cilta-cel. And so that's a big question. What does your hospital have? Because there are only 140 CAR T-cell centers in the U.S. and only 40 of them have all of the compounds available, which is very, very sad. But basically, I try to offer a CAR T to a fit person who can wait for manufacturing if they can't go on a clinical trial, but a lot of it is patient preference.
Yeah, and one thing I'd like to highlight is that CAR T eligibility is different than transplant eligibility. So the intensity of transplant is much more intense than CAR T. So patients in their early 80s, for instance, even with some products in the late 80s, could potentially get CAR T. So I think it's something that's more broadly accessible to patients based on their comorbidities and frailty as well.
And more recently, we can use BCMA therapy, right, in second line, and we can use CAR T or bispecifics. And so the landscape has really shifted for a lot of patients. At Huntsman, we typically start talking about CAR T in second line, certainly for all the high-risk patients, and often then
refractory.
do proceed with that. Yes. And we do use Ide-cel and cilta-cel, and the choice difference really depends on sort of the patient. And we offer both to them so that they can understand kind of what the potential for length of remission and expectations are, and then help guide their choice as they want.
But I do think one thing, just for our audience, that those of you who've taken care of CAR T patients can appreciate, there was this kind of like nice little slogan for a while, it's one and done. And what I try to tell patients when I see them, that's not right, because it's one and ongoing. So in many cases, you had the one infusion, but we have a lot of issues with hypogammaglobulinemia, so patients will be coming in monthly to receive IVIG, in many cases more than a year. And then there are you're going to talk more about this in terms of low blood counts that can happen. So I do think in terms of, what Dr. Lee was saying about setting expectations, I think you do have to tell people, as opposed to a stem cell transplant where the side effects are pretty predictable, like what's going to happen week to week, that the CAR T can be, it can have some ups and downs.
Mm-hmm. Yeah, absolutely. And it's really a caregiver or care partner is really critical during that CAR T. And we'll go into detail about the side effects, and you'll see why for those of you that might not do CAR T for a living.
Okay. Well, since I think we're talking about advantages and maybe disadvantages of some CAR T, I think this would be a good time to move ahead for Beth's presentation.
Great. There I am. I put these slides together myself, so I put a picture of me on there. So many of you have been in oncology for some time, and most of you are probably interested in hematologic cancers, which is why you're here today, and we appreciate you spending your lunch here. I do want to go over the CAR T-cell manufacturing delivery process. We talked about patient selection, and the important part of it for me, more than anything, because age is just a number, we look at fitness and frailty and patient preference. But I think the important thing is that there's time to manufacture. I'm working with a group that is trying to expedite referrals to cancer treatment centers who have CAR T, even at diagnosis, not for a second opinion, because that's assuming that the first opinion's wrong. It's just to collaborate and care and establishing that relationship, because we're moving CAR T really early on in the treatment. So most of you are probably aware of this, but just to level set, to make sure, we want to make sure to identify that patient. Maybe they're not a CAR T candidate today or tomorrow or next year, but having the discussion is important. A referral to a CAR T-cell specialist is really important as well, and it can be anybody within that treatment center too, right? So sometimes they want to come and talk to me or Mary about the CAR T, not for a CAR T consult, but just to gather more information. Patient support groups are also a good place to get more information as well. But then you proceed with the T-cell collection, and we want to be careful of the types of drugs we give ahead of time. I remember in olden days we said don't give melphalan up front because you might not be able to harvest the stem cells. That's not as much of a risk right now in myeloma, but there are some drugs that we want to hold, such as lenalidomide or so, for a couple of weeks ahead of time before the actual CAR T-cell pheresis. Then you're going to proceed with a period of time during manufacturing where you want to keep your patients safe. Many patients need a bridging therapy during that time, and interestingly, in many cases, there's some emerging data that suggests as much as you can keep them in remission, we are using like GPRC5D talquetamab for just like one ramp up during that bridging period to keep them in a good remission if they have very explosive disease especially. And then they get the lymphodepleting chemotherapy, so GFR is important. And then the close monitoring afterwards is really important. They have to stay in close proximity to the CAR T-cell center, but there are some periods before the CAR T-cell that they can be at home. So there's three main considerations, which are acute and delayed issues, such as cytokine release syndrome, that occurs different onsets about 1 to 2 days with ida-cel, 7 to 8 days with cilta-cel, immune effector cell neurotoxicity syndrome. A little incidence is less, but it can be about 4 to 5% or so, and then infection. And again, these patients can get cytopenic, and so if they have any of the CRS or ICANS, in parallel, we're going to work them up for infection. So when we look at the timing of the onset of these issues, so the CRS symptoms are listed on the left hand of the slide at the top: fever, hypotension, and that's part of the grading. You need a fever of 38 degrees Celsius or higher. That's your grade 1 CRS. It progresses to hypotension, not requiring vasopressors, grade 2, and then if it progresses and you're not treating that CRS appropriately, it can be more severe and they can end up in the intensive care unit. So don't do that. Treat your CRS. Potentially serious or other cardiac and pulmonary AEs, HLH, MAS, which tends to be rare. Neurologic complications can occur as well, and we do the ICE score, which we'll look at in just a moment. You can see the predictability of the CAR T cells from day 0 to day 28 is the picture here of what you can imagine the CRS with the expansion of the T cells. This is a picture of cilta-cel, which would be day 7. And then by day 14, that declines in the blood. So CRS onset and the neurological events we worry about, and then that's it. Next slide. I thought there was another little thing up there that didn't pop up, but that's a me thing. So what are some guidelines? So there's mostly institutional. Your institution's going to have the whole thing. But I'll tell you how we manage CRS in 2026, and ICANS is not how we manage it in 2022, because we have more knowledge. We were afraid to give dexamethasone because it might hurt the CAR T-cell expansion. We were afraid to give tocilizumab too early. And many of the guidelines that are written still suggest wait till grade 2, and I don't do that at my institution, and most of my colleagues do not either. If you have a fever of 38 degrees and you've had a CAR T-cell infusion, we tend to recommend at my institution 10 milligrams of dexamethasone with hydration, antipyretics, and tocilizumab. This is just a picture to the left of what are some recommended NCCN and other guidelines for management, and that you can download later so you can see it better than on my slide. These are some of the different recommended considerations when you have somebody undergoing CAR T-cell therapy. What are some of the things we need to consider as nurses? Have they had any cardiopulmonary imaging recently? And do they have a history of hypertension? Worry about AL amyloidosis concurrently, which is quite common in many of our practices, sometimes undiagnosed. Vascular access, they'll need a temporary central venous catheter is what we use these days. Seizure prophylaxis is in many hospital protocols for the first 30 days. Baseline and ongoing neuroevaluation. We don't worry as much about tumor lysis prophylaxis in myeloma patients, but if they have bulky disease, then that might be a concern. And then infection and immunoglobulin. Everybody has to be on TMP sulfa for pentamidine. IVIG, regardless of IgG level, is what we recommend. We do give CAR T-cells outpatient in many practices. This is my algorithm from my institution. Basically, anybody who has a good caregiver in close proximity within 60 minutes of the treating center, we see them on a daily basis. We give their lymphodepletion outpatient, their cells are back outpatient, and for many people, we reserve a bed at day 5 just in case they have CRS and need to be admitted, but hopefully they won't have to be admitted. We do not do prophylactic tocilizumab for CAR T-cell. That's been a hot question this week, but for for bispecifics, Mary will talk about that. And then we do routine laboratories regularly. This is just another picture for your reference of the medications to minimize infection risk. Again, weird atypical infections occur early on, and hopefully we can prevent those with moxifloxacin or levofloxacin if neutropenic, G-CSF, and other IVIG as well. I think that's about it. That's just some timing stuff. This is a boring slide. You can read that later on. Secondary primary malignancies, a lot of these patients, they can get these CHIP or CCUS, clonal hematopoiesis of indeterminate potential changes in their bone marrow, pre-MDS, secondary cancers. So just be very astute if somebody's having prolonged cytopenias as well. That was fast. They told me I had 5 minutes for that. I got it. 17 seconds left. Anyhow, this is a real life patient. This is a cool case because 78-year-old, who doesn't have hypertension and diabetes at 78? I probably have it now. And hyperlipidemia, high-risk IgA lambda multiple myeloma, gain of 1Q and 414, 80% bone marrow plasmacytosis. It was interesting, Dr. Callander's case had 83%. Our institution does it plus or minus 10%. So we aren't that granular. You have a cooler pathology department. So the first line of therapy, there was this Forte study, and back in 2018, we were giving everybody with high-risk KRD induction, autologous stem cell transplant, and then KD maintenance. Then he progressed and went on Darapom-Dex. The third line of therapy, we gave him Cilta-Cel. And the cool thing about it is that he's 78 and he wasn't like the fittest person. And the oncologist I work with, they're like, I don't want to give him Cilta-Cel, he'll die. And I said, no, let's just try. He had high-risk disease. He's been refractory. So I advocated. He got the CAR T. He's still MRD negative to this day. He did have some complications, though, and what happened was he ended up being admitted plus day 7. We tried to do it outpatient for CRS management, but it was a short stay, 4 days. But he had delayed side effects. He had a cranial nerve palsy almost by, I think it was day 28, left-sided facial droop. Went to the ER to be evaluated. It was a Saturday. We gave him dexamethasone, and that it resolved within 4 weeks, which was great. So again, education to the patient, education about the signs and symptoms to look for, and don't ignore anything just because it's the weekend. So I think, is this for you, Dr. Callander, to ask the panel?
Yeah, no, I think, so how many people in the audience here are involved with CAR T right now? And show of hands. So pretty big number. Okay. And I think because we are all trying to make sure that we have great transitions of care and referrals, what do you see as some of the barriers that we need to get over to get patients to CAR T? And how can we best interact with our community nurses?
So I think Beth said it really well, early referral. So patients, you can start talking to patients about the potential for CAR T therapy really once they're kind of used to their induction or first-line therapy. And then early referral to CAR T centers allows that CAR T center to get to know the patient, kind of plan out a timeline. I will answer a little bit about this transition of care, though, because it's something I'm very passionate about. So communication is key here, right? And one of the important parts of, as nurses, we communicate hopefully well. You want to understand what the referring center needs and then what the tertiary center needs. And so I think nurses play a really important role in this. Sometimes the best way to communicate is over the phone. Sometimes it's by faxes still where I am. But then if there is communication between electronic medical records, that actually makes it way easier, as we all know. But I think as nurses, our role is to define what the best pathway for communication is and then ensure that happens.
And Mary's in the Intermountain West region, and there's very few CAR T cell centers in her area. They have to go to Utah or where else?
Or Seattle or Southern California.
So it's the geography is, and Dr. Lee was in Texas, and it's the same, geographic barriers are huge. So if you can just bridge those geographic barriers, there's a lot of travel grants available. We talked about that yesterday, to get you to that CAR T cell referral center to see if you want to go on the CAR T.
Yeah, I'd just like to emphasize how important nurses and advanced practice providers are important in the patient's CAR T journal. They're absolutely critical in that communication piece, really providing the link oftentimes between the local center and the tertiary center in patients getting CAR T therapy. And so just being aware of potentially warning symptoms of some of the late toxicities, I think, is really important. And if a patient then calls, and you can appropriately triage patients accordingly, should they stay in their local center and get managed there? Should they come back to the tertiary center? So these are all really, really important things. Again, the APPs and RNs are on the front lines. They're so critical to our center and many centers across the country.
Yeah, clear and concise communication and a structured handoff are the strategies that we try to employ at our centers, and getting that phone number of who to call is really important as well. Not everybody has an electronic medical record. That makes it a little easy. And you don't want to put the onus on the patient, but give them a piece of paper. Tell them you need to be on IVIG monthly when you go back. You need to stay on Bactrim until your CD4 counts over 200, and make sure that they know who's watching their myeloma labs to ensure that they stay in remission and they aren't progressing rapidly, unexpectedly.
Yeah, and I also would add, I've tried to make sure that our nurses, when they're supporting patients who've been through CAR-T, to highlight the differences in some ways. So when people have an autologous stem cell transplant, they obviously lose their hair. They're kind of visually looking like they've been through something. And I think they get great, or not always, but I think they get a lot of wonderful support from their families and friends. And so when people go through CAR-T, they don't look that different. Mm-hmm. They may not have had the kind of weight loss you see with an auto transplant for myeloma. And my patients have uniformly told me they are fatigued. They're fatigued for months after CAR-T. That depends on, it doesn't seem to matter whether they have cytopenias or anything like that. But I really try to tell people to don't be shy to ask for help, to make sure that people know that you've really been through this process that's sort of agitated your immune system, if you will. And I do think sometimes that patients really need to be supported, and our nurses are very good at saying, yes, this is normal. I would say 6 months, a lot of the patients feel pretty good, but it takes a long time.
Yeah, those prolonged cytopenias are a challenge, though, sometimes.
Yeah, and I was also going to mention that for those of you who are involved with CAR-T, it's a great opportunity to educate peers who are not involved with CAR-T. So again, those who practice at CAR-T centers are administering CAR-T therapy, and then you can educate those nurses and APPs that don't have exposure to some of these therapies on a recurring basis. And so there's a great opportunity for this cross sort of pollination of different pearls, and also to hear back from them about what we could do better as well.
Absolutely.
Well, Mary mentioned bispecifics, so we're going to move on here and turn the table over to Dr. Lee, who's going to tell us about bispecifics.
Great. Thanks, Dr. Callander. So I'm going to be talking about bispecific T-cell antibodies in multiple myeloma. This is a very exciting therapy that's emerged over the last 3 to 5 years. So the first question is, what is a bispecific T-cell antibody? So these are basically two-armed antibodies, where one armed antibody binds to an antigen on the myeloma cell. The other arm of the antibody binds to CD3 on the T cell, and it brings the T cell and myeloma cell in close proximity. It's like the kiss of death. And it leads to hopefully a lot of T cell mediated cell killing of the myeloma cell. So I really like to start out with this slide here. It really shows the progress in myeloma over the last 3 to 5 years, particularly with the advent of what we call T cell redirecting therapies, including bispecific T cell antibodies and CAR-T therapies. So on the far left of this slide, you see some of the older myeloma drugs, maybe approved in the last decade or so: Pom-Dex, Carfilzomib-Dex, Daratumumab-Dex, Selinexor-Dex. And basically, in the initial clinical trials that led to the approval of these agents, we saw over-responses really ranging from 25 to 30%, over-response rates defined as at least a 50% reduction in the myeloma, and the progression-free survival was usually around 3 to 4 months. And then fast forward, particularly in the box here, are the bispecific T-cell antibodies approved for myeloma: teclistamab, elranatamab, linvoseltamab, talquetamab. And you see now really an unprecedented over-response rate for an off-the-shelf agent. So for conventional drug, over 60% is what we'd expect with bispecific T-cell antibodies. Not only do we see very high response rates, most of the responses are very deep, so very good partial response or complete response, and they tend to last very long as well. So these are really unprecedented, activity in terms of efficacy against myeloma and really late-line, heavily pretreated patients. And so, as I mentioned earlier, there are several now approved for the treatment of relapsed refractory multiple myeloma. I listed them here on this table. Most of them target BCMA, including teclistamab, elranatamab, and linvoseltamab. We do have one that's FDA approved that targets GPRC5D, talquetamab. Some are given subcutaneously, some are given intravenously, like linvoseltamab. Most are currently approved in patients with at least 4 prior lines of therapy, although we just had a recent approval of daratumumab and teclistamab for at least 1 prior line of therapy just a couple months ago. And this was based on the Majestic-3 trial. So this was a trial presented initially at the American Society of Hematology meeting last December. This was sort of this mic drop abstract presentation. We were just, I think everyone in the room and all the myeloma community were just astonished by the data here. And so long story short is that we saw basically a randomized phase 2 trial of teclistamab with daratumumab versus standard of care triplet-based therapies. And basically in the red curve there, you see the progression-free survival of daratumumab, teclistamab. In the black curve, you see the progression-free survival and overall survival of the standard of care triplets. There's a huge magnitude of difference. We can see a hazard ratio of 0.17. Basically what this means is this is like the most positive study in the history of relapsed refractory multiple myeloma ever probably presented. And so with such compelling results, this was actually fast-tracked by the FDA. From the time of submission to the FDA to the time of approval was less than 2 months. So it really shows that this is really an unprecedented regimen that is available for our patients now in patients as early as 1 line of prior therapy. And so it's really great that patients have access to these therapies earlier on. If there is one criticism of the Majestic-3 trial was that most of the patients enrolled in the trial were not exposed to this drug called daratumumab. And so actually shortly thereafter in January of 2026, there was a press release from the Majestic-9 trial. So Majestic-9 trial basically evaluated teclistamab monotherapy compared to pomalidomide, bortezomib, dexamethasone, or carfilzomib, dexamethasone, which are standard myeloma treatment regimens. Long story short, a significant improvement of progression-free survival seen and an overall survival in this trial. This data will be presented at the ASCO meeting in Chicago in about 4 weeks or so. So we're really looking forward to that data as well. But the important thing about this trial is that most patients were refractory to daratumumab, so all patients had to be exposed to IMiDs and anti-CD3 monoclonal antibodies. So again, more heavily pretreated patient population, really showing the same result, improvement to PFS and overall survival. And then I did want to mention that the Monumental 1 study, this was the trial that led to the initial approval of talquetamab. This is the bispecific antibody that targets GPRC5D. Again, very high overall response rates, over 70%. What was also very interesting, not shown on this slide, that we saw responses in patients who were exposed to prior BCMA-targeted therapies. So this is also a great option in patients who've had BCMA CAR-T, who've had BCMA bispecific antibodies, that talquetamab that targets GPRC can be very, very efficacious in this this context. So really, in summary, I think there's a couple key points with bispecific antibodies really representing a transformative therapeutic option for patients with relapsed refractory multiple myeloma. I think there's a couple of reasons why. One, they have very strong efficacy. Secondly, they're accessible. They're off the shelf. So patients can get these therapies at major academic centers, major myeloma centers, but also in the local community as well. And the side effect profile is generally manageable. So in terms of who can receive these therapies, most patients can receive bispecific antibodies who have multiple myeloma. And these agents will form the backbone of myeloma therapies for the years to come. We're seeing really, really interesting frontline data as well. So again, these therapies will be used for many, many years, will form the backbone of myeloma therapies, again, for the foreseeable future. So with that, I want to present a quick case. So this is a patient, 82-year-old gentleman, so a little bit older, with relapsed refractory multiple myeloma. Patient had high-risk disease with something called deletion of 17p, had renal failure and bone lesions at the time of diagnosis. Note that he was diagnosed in 2022, and he has had several previous treatments, but actually had very short durations of response to these therapies, much more shorter than we'd expect with typical patients, largely due to the high-risk myeloma. And the patient was on carfilzomib, cyclophosphamide, dexamethasone, had rapid progression of his myeloma, really with rising myeloma biochemical markers. So discuss the options with this patient. The patient's independent. He actually has very good performance status, lives alone, has some family support locally. He has some common comorbidities that we might see in myeloma patients in this setting. So discuss CAR-T therapy, but as Beth went over the details of CAR-T therapy, you have to undergo collection and manufacture and infusion of T cells. This patient's rapidly progressing, so a bispecific T cell option really made sense for this patient. And so the patient was treated with linvoseltamab, which is one of the BCMA bispecific T cell antibodies approved for the treatment of relapsed refractory myeloma, was initiated. Patient did receive prophylactic tocilizumab, had grade 1 CRS, which was just a single fever, was really managed with Tylenol, did very, very well, no recurrent CRS or ICANS, and the patient has had a very good partial response to therapy. And notably, this is the deepest response the patient has ever had to their myeloma ever compared to any of the previous therapies. And so, again, highlighting that, elderly patients, rapidly progressing disease can do quite well with some of these therapies.
Good job. You cured him.
Yes.
Well, I think, one of the key questions that these presentations bring up now is we just saw these amazing results. So people getting teclistamab and daratumab, it's like they're 93% better than the alternative based on or 83% based on what that hazard ratio was. But I guess I would ask now, when you're counseling a patient, why would you pick a CAR T for their second therapy versus teclistamab and daratumumab?
Yeah, that's a great question, Natalie. And so, my perspective is the patient should get, in second line, the best therapy that they have access to. So if that's a CAR T therapy and the patient has preference for CAR T therapy due to potential time off therapy, then CAR T is a great option. If CAR T is not an option due to logistical reasons and a bispecific T-cell option is available, patients should get that option. So I think the notion of saving your therapy until later, like let's say I could potentially get a CAR T third or fourth line, so I'll skip the bispecific because even though I have access to it, I would not recommend that. Patients should get their best therapy that they have access to second line.
Yeah. And like we heard Dr. Callander say before, it's not one and done. It's a single infusion of a cellular therapy, but it's then some. The then some for bispecific like Tec-Dara is ongoing bispecific antibody therapy and ongoing Dara. Now, it's a little bit shorter than what we give currently in this study. We won't talk about the dosing right now, but the CAR T, it's just IVIG, supportive care, and they tend to feel pretty well with that therapy as well. So we really try to get folks to that. And we just did an 86-year-old for CAR T-cell therapy, too, with Cilta-cel, did great. So age is really just a number. It's the fitness and frailty.
Yeah.
And caregiver support.
Yeah, that's a big component, right? The caregiver support. And so Dr. Lee said it beautifully. The patient should get what their best next therapy is. And sometimes it's going to be the bispecific because of travel logistics or the logistics of CAR T or patient preference.
And we talked about how geographically it's just not available CAR T in many situations. So if you're sitting in the audience and your center has transplant but no CAR T, advocate for trying to find out what's necessary to integrate the CAR T-cell therapy program into your hospital.
And I would think that one take-home message from this program is that bispecific T-cell antibodies can be given anywhere. And so Mary's going to go over a lot of the mitigation strategies for CRS, toxicity management, but I would challenge the audience that if you're not giving bispecific T-cell antibodies at your local practice, ask your doctor why, and try to figure out how to get it. Because the beauty of bispecific T-cell antibodies, you're seeing results, it's really on par with CAR T in some cases. And so this presents an opportunity to really equalize the playing field in terms of access to therapies. Patients need access to these therapies where they live and where they're getting treated.
And your case study had prophylactic tocilizumab, and that's another key point. It's in the NCCN guidelines, and I have not had any problems with reimbursement. So once you give prophy-toci outpatient, we've seen data, and you'll show this as well, that can help ameliorate.
So a perfect segue for you, Mary.
All right, here we go. So let's get into some of the practical issues and the toxicities that we can see with bispecific therapy. I'll skim over how they work because Dr. Lee did a great job of that. We do have 4 drugs available to patients with relapsed refractory myeloma, and we see them again there. Notably, linvoseltamab is given IV, and the other 3 are sub-Q. So here we get a look at the step-up dosing. And step-up dosing with these bispecifics is very important because it mitigates the risk for cytokine release syndrome and any ICANS events. And so you can see how the doses play out for each of the drugs here, and then what the process is. And this is how patients end up getting their bispecific is going to be very institution or practice specific in terms of, are they admitted to the hospital for monitoring after step-up doses? Do they stay outpatient? At Huntsman, we are delivering all our bispecifics in the outpatient setting. We are using remote monitoring of temperature still, and I say still because we are aiming to stop that. It's probably a little bit of overkill to continuously monitor a patient's temperature after bispecific. And the reason, if you think about the mechanism of action of these drugs, is they just kind of get this small dose that causes a cytokine surge, and then a couple of days go by and they get another dose. Unlike the CAR T setting, as Beth explained, the CRS and ICANS there, when the whole dose is happening at once, and then there's rapid T-cell expansion. So although CRS and ICANS occur with all the T-cell engaging therapies, there really is a difference in the nature of the cytokine release syndrome and ICANS with bispecific antibodies. And that's an important point, because hopefully it helps you feel that these are safe to give wherever the patient is in community practice. And then pre-medications are a big part of this, right? So these drugs are great because long-term patients don't need dexamethasone with them, but during step-up doses for all the products, we should be giving pre-med. So a little bit of acetaminophen, Benadryl. The dex dosing can be institution-specific. We try to give lower dex than we historically have. In the label, though, there are differences in the dex dose based on the drugs, so make sure you double-check that. And then to bring up tocilizumab, with it in the NCCN guidelines, it is very easy to get approval for it. I would say some private insurances may sort of lag in their potential for approving it, but we are giving prophylactic toci to the majority of patients, and it really does decrease the risk for cytokine release syndrome, which keeps patients feeling better out of the hospital setting. I mentioned, you may, as you begin to onboard bispecifics, you may be admitting patients for monitoring during step-up dosing. Sometimes it's just easier on the system. If you can do them outpatient, you want to be able to set up kind of pathways for the patient in terms of phone triage, after-hour calls. And I think nurses play a really important role in kind of setting up these procedures for the practice and then educating the patients on what to do based on fever. Here, just broadly look at how cytokine release syndrome happens across all of the bispecifics. So I lumped it all together. And it's really about 60 to 75% of patients without receiving tocilizumab do have the potential to have cytokine release syndrome with their bispecific antibody. Thankfully, there essentially is no grade 3 or higher CRS. So typically what we see is fever. And then the onset can happen 1 to 3 days from whatever the most recent step-up dose was, and it typically doesn't last long. Even if you don't treat it, the cytokine release syndrome doesn't last long in these cases. And of course, if you're treating it with dexamethasone or a dose of tocilizumab, it goes away very quickly. This is the grading for CRS, and this is set by ASTCT. Essentially, you cannot have CRS without having a fever. Hopefully, we are all kind of well aware of that point, so I won't belabor it. Things you can do is certainly support the patient's symptoms during that fever event, so they can have Tylenol. Maybe they feel better with some IV fluids. You do want to consider the potential for infection in all these patients because, number one, BCMA drugs do cause infections for patients, but also most relapsed refractory myeloma patients are susceptible to infection. So always consider that as a patient has a fever. The neurotoxicity that occurs with the bispecifics is really very minimal, and this is some pretty conservative recommendations here to do an ICE score for patients twice a day during their step-up dosing. Our practice is to do it prior to each step-up dose, and I really do look forward to the future when we probably stop doing this, which is coming. I think most typically patients for neuro events related to bispecifics are a headache, and it can be common after 1 to 2 days after the dose, they may experience a headache. People who have ongoing headaches through their bispecific, that's the type of patient we're just going to keep on a little bit of dexamethasone before each treatment. So the persisting toxicity is kind of long-term when someone is on a bispecific. You do always want to consider the risk for infection. Talquetamab, being a GPRC5D target, has a little less infection potential, but again, most patients who are receiving talquetamab have had a lot of prior treatments, and so they may have a decent amount of B-cell depletion and hypogammaglobulinemia. All patients on bispecifics should be getting IVIG monthly, and the newest recommendation, thank goodness, is for the duration of therapy. So this is in the NCCN guidelines now and allows us to give patients IVIG monthly. Cytopenias can occur. I think more typically this is seen earlier in the treatment cycles, and certainly long-term when patients remain on their bispecifics, you see less cytopenias. And you do always want to consider kind of other lab abnormalities that can occur. There can be some transaminitis seen with all the drugs, and so we should be getting CBCs prior to each dose. And then can't really finish this discussion without talking about the skin and nail changes and taste changes that can happen with talquetamab. Because GPRC5D lives on keratin cells, a lot of patients are going to have taste changes, dry mouth. That tends to happen pretty early in the step-up dosing on talquetamab. It can get better over time. And then rashes tend to have a little later onset. Patients can have sloughing of the palms of their hands and their feet. And so you guys who do more than just take care of myeloma patients are pretty familiar with how to handle skin toxicities, and the recommendations are the same. Just to close on our bispecifics, so if CRS is going to occur, it's going to happen during the step-up dosing of all the drugs. You can really mitigate and decrease the potential for this by giving patients tocilizumab up front. And certainly, similar to in the CAR T space, you treat CRS when it occurs. Neuro changes most commonly are headaches. I'd love to be able to give a bispecific talk with leaving out the ICANS and the neuro potential, because you just really don't see anything dramatic. And then infections are sort of the key to consider for patients long-term as they're on therapy. And then as patients get talquetamab, just upfront education about the symptoms that they may experience is very helpful. Thankfully, the majority of patients respond very well to talquetamab, and then you can de-escalate the frequency of dosing, and that helps with these symptoms.
I love your slides, Mary. They're so pretty.
Thank you. I had some AI help, which is like so obvious when you look at it, but
they look great.
They are pretty. So here's my case presentation. This is a 62-year-old woman with RISS stage 2. So she was diagnosed in a couple of years ago. She had quad therapy up front, auto transplant, was in a CR, though MRD positive. She was eligible for a clinical trial in the maintenance setting. So she ended up receiving CD38 monoclonal antibody isatuximab plus lenalidomide. With an RISS stage 2 patient who's in a CR but still MRD positive, we would hope for a few years at least, right, out from induction and transplant for this patient to be in remission. She unfortunately had an early relapse, which then suggests, right, the biology of her myeloma is higher risk than what it was staged at presentation. This is the type of patient who is a total go-getter and up for almost anything, and so she was really enthusiastic about going on a clinical trial at second line. So we have Monumental 6 open, which offered her the potential to receive talquetamab and pomalidomide. So only on clinical trial are you able to get these two drugs together in this space. I'm talking about her case because although she's such a go-getter, she did have CRS after her first step-up doses, but
she didn't get Profitosi, though.
She did not get Profitosi, but she also didn't tell us, right? So she's at home and has a fever and doesn't call us. She felt very well, right? So she had just measured her fever because that was the recommendation, didn't call us. See her a couple of days later. Of course, I'm like, why did you not call us? How many, you educate and re-educate, but yeah, she had just felt well. And it struck me at that time, she went on to fever a couple of times before she saw us back, but nothing ever came of it. And so I use her case because it's an example of cytokine release syndrome with a bispecific, but there's no consequence to it. She had taken some Tylenol on her own, felt fine, did well. She finished all her ramp-up dosing, but did then have another recurrent fever. And at that point in time, the protocol allowed us to give tocilizumab, so we did. No fever since. She has had some ongoing skin and dysgeusia changes. So she is using this miracle berry. I don't know if anyone has heard about this.
Yeah,
you guys
they're from Europe.
Recommend
They can give you a sweet taste.
Yeah,
that lasts for a while. Yeah,
it kind of helps activate salivary glands and can help patients with taste changes. She is doing great. She's about 3 cycles in at this point and in a CR, and her skin changes have improved, her taste changes have improved, and she's doing well.
Great. Okay, well, we just have maybe time for one question. Again, what do you tell people, and I will just say my experience with the BCMA-targeted bispecifics is that there are some people who get chronic rhinovirus infection and they will quit because they're sick of feeling stuffy all the time. I don't know if anybody's had that experience, despite IVIG.
Yes, absolutely.
That chronic congestion
is
so annoying.
aggravating for
Yeah,
people.
it's really
and it's really
aggravating.
fatiguing.
Yeah.
Right?
I mean, I think we all try to space out the treatments, and that may be helpful, but I think it's kind of an maybe a somewhat unrecognized, but kind of an annoying problem.
Maybe I'll ask you, I know we have to move on, but
Yeah.
I think one of the hottest questions is how do you determine if you have 3 BCMA bispecifics on formulary and you want to give a BCMA bispecific, how do you determine that in your practice?
That is a whole long discussion, and I think we're going to have Dr. Lee talk to us about antibody drug conjugates right now. Thank you.
All right, sounds good. All right.
Moving along.
So we're going to move on and talk about antibody drug conjugates that target BCMA, namely Belantamab, Mafodotin. And so I think the common theme is BCMA is a very good target in myeloma. There's 3 ways to target it: CAR-T therapies, bispecific antibodies, and antibody drug conjugates. So Belamaf, I'm going to refer to Belantamab, Mafodotin as Belamaf from now on, is an antibody drug conjugate which antibody portion binds to BCMA. It's linked via a non-cleavable linker to a chemomoiety. So MMAF is basically a chemotoxin. And so you can see here there's multiple mechanisms of action, including the ADC mechanism. There's some immunological mechanisms of action. I think something that's very interesting is this immunogenic cell death. So essentially there's some data that suggests that Belantamab, Mafodotin can train the immune system to essentially have adaptive immunity against myeloma for hopefully durable responses. And so Belamaf actually was initially studied in the DREAM2 phase 2 study. This enrolled heavily pretreated patient population, more than 3 prior lines of therapy, who were largely what we call triple-class refractory, and basically looked at 2 different doses of Belamaf. At the 2.5 milligram per kilogram dose, dosed every 3 weeks, we saw over response rate about 30% or so. I think what was very encouraging was that among the patients that did respond, the median duration response was actually almost a year. There was some notable toxicities, though. So one of the unique toxicities of Belamaf, which you may be familiar with, is this ocular toxicity, which manifests primarily as keratopathy. And so this actually did initially lead to the approval of Belamaf in the late-line myeloma patient population back in 2020. Subsequently, there was a study of Belamaf versus pomalidomide and dexamethasone, the DREAM3 study, based on head-to-head comparison in patients with at least 2 prior lines of therapy. As you can see from the bottom table here, that while there is a numeric increase in progression-free survival with Belamaf versus pomalidomide and dexamethasone, there was no difference in overall survival, and the median PFS difference did not reach statistical significance. So this was considered a negative study to the FDA. And so, unfortunately, Belamaf was actually withdrawn by the FDA in 2023 based on this study. But this is not the end of the story. So at the same time, there were a couple ongoing trials that were enrolling at the time, the DREAM7 and DREAM8 studies. So the DREAM7 study looked at Belantamab in combination with bortezomib and dexamethasone versus daratumumab, bortezomib, dexamethasone. So essentially a head-to-head trial between daratumumab and Belamaf. And this enrolled patients with at least 1 prior line of therapy. And basically, the take-home point was that there was a significant improvement of not only progression-free survival, but overall survival. So nearly a tripling of PFS benefit with the Belamaf-based combination versus the Dara-based combination. So this is pretty compelling data. And so this did lead to the approval of Belantamab Mafodotin in combination with bortezomib dexamethasone in patients with at least 2 prior lines of therapy by the FDA in October of 2025. And then at the same time, there was another study called the DREAM8 study ongoing. This evaluated Belantamab Mafodotin, pomalidomide dexamethasone versus pomalidomide bortezomib dexamethasone, again enrolling an earlier line patient population, 1 line of prior therapy. Although more of these patients actually were len refractory, so about 80% of patients were lenalidomide refractory, about a quarter of patients were refractory to anti-CD38 monoclonal antibodies. And there was a significant improvement of progression-free survival with the Belamaf-based combination. As you can see on the Kaplan-Meier curve here, there is a trend towards overall survival benefit on this trial, though with longer follow-up, perhaps we'll see a significant benefit there. And so based on this data, it's not approved yet in the U.S., but it is approved in Europe in patients with at least 1 prior line of therapy, the combination of Belamaf, pomalidomide, and dexamethasone. And so really in summary, Belamaf is a generally well-tolerated off-the-shelf approach, and there's no risk for CRS or ICANS just because of the mechanism of action. It can be an option, particularly in frail and elderly patients. It can be given in the community oncology setting. You need to partner with your local eye care specialist for management of potential ocular toxicities. And again, it's approved for patients with at least 2 prior lines of therapy in combination with bortezomib and dexamethasone in the United States. So switching gears to a case presentation. So we have a 79-year-old woman. She has relapsed refractory multiple myeloma diagnosed in 2019. She has standard risk myeloma, initial presentation with bone lesions and anemia. The patient received VRD induction. That's what we did back in the day in 2019. She declined transplant, didn't really have much of a social support system, continued on lenalidomide maintenance therapy through 2024, had a nice response to therapy. Second-line therapy with daratumumab, pomalidomide, and dexamethasone, and patient did well for a while, but then has had slow rising of the biochemical markers with M protein 0.4 to 1.1. And so discuss treatment options with the patient. So she lives about 45 minutes away from her local oncology office. She has a pet dog that she cares for that's really important to her. She has 2 adult children that live out of state. Other medical history includes type 2 diabetes, hypertension, and osteoarthritis of bilateral knees. So discuss CAR T therapy, but this is not feasible because she doesn't have strong caregiver support. And again, she lives 3 hours away from the nearest CAR T center. And also discussed bispecific T-cell antibodies, although it wasn't approved at second-line therapy at the time, but she still needs caregiver support during the step-up dosing period with bispecific T-cell antibodies, and she wants to also make sure that her dog is well taken care of as well. And so ultimately decided to go with Belantamab, Mafodotin, bortezomib, dexamethasone as per the recent approval. I will note that started at a lower dose of Belantamab, so 1.9 mg per kg instead of 2.5 mg per kg. So I think one of the take-home points I really apply is dosing off-label. So the dosing is usually 2.5 mg per kg every 4 weeks or every 3 weeks, depending on the combination. But again, the responses tend to last quite a long time once a patient responds. So I start at a lower dose, spread out the doses. So once a patient is responding, as you can see here on the later part of the case, the patient had an initial response after 1 cycle of therapy, some grade 1 keratopathy, which was not clinically significant, had no symptoms at all to that. And so quickly decrease the dosing frequency from every 4 weeks to every 8 weeks. She maintains on this every 8-week dosing and with really limited keratopathy. So again, I think Belantamab is a very good option for patients. I think if you dose it in the right way, again, spreading out the doses, starting at a lower dose, it's really, really critical to mitigate the risk for some of these ocular toxicities. And even going to every 12 weeks I think is something that's very reasonable as well. So I want to close with that, and I'll turn it over to the next speaker, actually, Natalie.
Well, thank you very much. How many people here in the audience have had a patient on Belantamab? Just out of curiosity. Very few.
Yay.
Okay. Well, I think, this is, I think Hans really laid out some of the difficulties that were occurred because of approval, no approval, back to approval. And we've had the advantage of having these trials open for many years. I still have a patient who was on DREAM 2, still on Belantamab, and has never progressed, and that's 9 years ago. So these drugs are great, but how do you sequence them in terms of other options that you have now for all of the panel here? Mm-hmm.
Yeah, great question. So I think the great thing is that we have many options for patients in second and third line therapy. Like I mentioned earlier, patients should get treated with the treatment that makes most sense for them that they have access to. So the case I presented, CAR T and bispecific doesn't make sense for this patient, right, due to a lot of social issues potentially. So again, Belantamab, Mafodotin is a very well-tolerated drug. Again, if you dose it the right way, spread out the doses, it's a very effective option for patients as well. I do want to mention, though, that a consideration for Belantamab is actually on the back end of CAR T and bispecific, so due to the mechanism of action. So unlike CAR T therapies and bispecific T-cell antibodies, which require good T cells, so you have to have good T cells to exert its mechanism of action, Belantamab does not require good T cells necessarily. So you actually can see responses in patients who had previous BCMA CAR T or BCMA bispecific T-cell antibodies on the back end, and anecdotally, we've seen some very nice responses in that context.
Can I do a 10-second add to that? So again, as he mentioned, it's not a T-cell engager, it's an antibody-drug conjugate, and so you can target BCMA, and you're going to hear from Mary, you don't have to use Tylenol, you don't see CRS, you don't see ICANS, so this lady was perfect for Belantamab. So keep in the back of your mind.
Yeah, well, should we move on to Mary and your presentation?
I don't know what this clock means. I don't have any idea if we're behind or ahead.
I got you. I got you.
Good thing you're the moderator.
Okay, so how do we get people started on Belantamab? And let's talk a little bit about the tolerability. Again, Dr. Lee did a great job, so I'm not going to talk about the mechanism of action there. He let us know about Dream 7 and Dream 8 and why we're able to use Belantamab again here. So the eye toxicity, right? This is a big deal. Whenever you say eye toxicity, it scares patients. And I know a number of providers who this eye toxicity potential scares. My experience with it, I actually really love this drug. It works very well. And you don't, if you can mitigate the ocular toxicity, space out the dosing, patients really can do very well. So it's important to educate your patients about that. The ocular toxicity that it is likely to occur. Patients, it's recommended that they use eye drops frequently, right? You cannot use eye drops enough in these cases. And really anyone with dry eyes knows that. So I'm always telling patients, keep your eye drops in your pocket. Every couple of hours, they should be using those to keep their eyes lubricated. They do need, so there's a REMS program associated with this product, and they do have to have ocular exams before each dose. So you guys who take care of myeloma patients are good at REMS. Nurses are at the forefront of leading this. It's about the setup in the beginning, and I think I have this on a slide. So you want to refer patients to either their local eye person, if they already have an eye provider that they're seeing. And I say eye provider because it does not have to be an ophthalmologist. They do not have to be seen at a specialty center. They can go to Costco for this testing. They can go to lens crafters. They essentially need a visual acuity test and that slit lamp exam prior to every dose. And then whoever does that for them fills out the sheet of paper, and that comes back to the clinic, and their drug can be released. Mm-hmm. They need to have a baseline eye exam as well, and then prior to each dose, as I said. So as nurses, you have the ability to kind of set the stage for this for patients in the beginning. We tend to just schedule everything out for a patient from the very beginning. So when you decide when day one is, you just get in this patterned routine of them having an eye exam before. You can see on this slide kind of what is done in the eye assessment, as I mentioned, and then when do they happen. So there are some maybe tricks to the trade for reducing ocular toxicity, and I think probably at one of our myeloma conferences coming up, we'll hear some more data on this. But as Beth mentioned, you don't need to give pre-medications for this. There's some patients should be on IVIG when they are on Belantamab because it is a BCMA drug. And then when they need to hold based on ocular toxicity, you can decide with the patient, do they want to wait a week before having their eye exam done again and trying to get a dose, or do you just wait till prior to the next dose? What's your guys' practice with that?
I am really quick to reduce the dose. I feel like this is such a great drug, but you don't have to give. We always start at the target dose because I think it's important, especially based on the relapse. But as quick, hold the dose and de-escalate. I have patients that were off it for like 8 months and didn't need another dose.
Yeah.
It's very effective in some.
Okay, so what are the other toxicities that can occur with Belantamab? Patients can have thrombocytopenia. They can have an infusion reaction with that first one. That 20% looks kind of high to me.
That's too high.
It doesn't actually happen
too high.
In practice that way. And then, of course, because it is a BCMA-targeted drug, they are at risk for infections as well. And I think transaminitis is definitely something you see when patients are on Belantamab. So what are the take-homes before we get to the case? You want to set up those eye exams prior to them starting, set the expectation for the eye provider and for the patient themselves. Dry eyes occur even outside of outside of like vision changes, so using lubricating drops is very helpful. Hold as soon as there's any changes, dose reduce as you need to, and then empowerment of the patient is probably the key choice in this. So as I mentioned in the beginning, patients are afraid about their eyes changing, right? For some people, obviously, we all rely on our eyes, but like reading and watching TV are kind of like the key things they like to do. So I just always try to let patients know this is not permanent. So when you hold the drug and then over time, ocular changes.
Can I add in 2
help.
points?
Yeah.
Don't wear contacts. I always forget to tell people to not wear contacts. And then driving. What do you do with driving? Because we do a lot of rideshare services and encourage driving or somebody else to drive them. Do you recommend anything?
Actually, don't mention driving to patients, but
They're different in Utah.
We let everyone drive.
More spread out in Utah, right?
I know. No Uber and...
Okay, let's get to the case, which actually I set up beautifully.
Beautiful
that goes
women.
along with our
Wow.
first, with our discussion about after BCMA. So this is a 67-year-old woman who ended up getting anito-cel on clinical trial as her third line of therapy, and then she had almost 3 years of remission after this. And then just recently has a biochemical progression. So in this 3 years from her CAR T, this woman just maximized her life. She was living so well. She retired from her job, traveling, always with her family. So it was really a disappointment to her to consider another line of therapy. She'd gotten very accustomed to not being with us. So we talked to her about kind of all the potential. Someone in this space, 3 years from their last BCMA, sort of has everything available to her. And she decided to go on Belantamab, which, you could argue is sort of an interesting decision at this point. But as we mentioned previously, it gives her T cells a break, right? So after CAR T, and maybe she'll have a better chance on a bispecific later on if she can get kind of space from a T cell engaging drug. She was not worried about the eye toxicity. She was really interested in spacing out dosing, so being able to get, to every 8 weeks just coming in for something. So she did start on Belantamab, and she is doing great. She does not have any ocular toxicity and is really thriving. I want to just also add that not every patient has ocular toxicity, and I've even have patients who vision improves once they're on this drug, which I actually think is just from using eye drops a lot and kind of solving their dry eyes. So although it's a big tag feature that we talk about with this drug, the ocular toxicity is treatable, and it's not a reason not to treat patients with this drug.
Yeah, and talquetamab would have been an option for her, GPRC5D bispecific, but it's scary too, right? Like the keratinized effects can really be frightening for patients. So, good job.
Yeah, and I think just to close that, one thing that I would suggest to people in the audience, and this is what we did, is you do kind of have to find an ophthalmology or an optometrist who's interested.
Yeah.
So we happened to luck out. We had somebody whose relative had myeloma, and they were very interested in this. And so it is a partnership. I think you have to develop a little bit so that everybody's comfortable. So there is a little work, I think, to get going. But Beth and Mary, I would agree with you. This is so easy for patients compared to a lot of the other things that we give them. It's just and then
community.
As Hans said, there are definitely people who are fine 3 months, 6 months out between doses.
Yeah,
for sure.
And there's no steroids as well
no steroids.
that you don't have to do.
Yeah.
So typically, yes.
Yeah.
It's like the best thing since sliced bread. Doesn't it sound like it's
Yeah.
like everybody should be on Belantamab. Forget about CAR
Okay,
T.
well, we're going to leave T-cell redirecting therapy alone, and we're going to move into cell mods. And the interesting thing for the audience here is there's cell mods coming in other blood cancers too, lymphoma for sure. Mm-hmm. So we're going to talk to you a little bit about what's happening in myeloma. So what is a cell mod? All right. Well, a cell mod is basically a drug that's related to either lenalidomide or pomalidomide. And how these work is there's a little purple protein there that is Cereblon. And the job of this complex, I won't tell you the whole name here, is to help destroy these many proteins, but two in particular, ALOS and Icaros. And these help myeloma cells grow. So if you get your Cereblon to help get rid of these, you're going to be in better shape fighting your myeloma. So these drugs have the ability to bind to this and keep it open for business. So they can degrade a lot of these proteins, which is a pretty cool mechanism. But there's more, because They're very much more potent than both pomalidomide and lenalidomide, and they look like they may actually make T cell function better, which is a pretty exciting feature of these. Now, the nice thing about them is, and what that graph is showing you is even a little doses kill a lot more cells than the top lines, which are lenalidomide and pomalidomide. But the exciting thing about these drugs is they're given in a very familiar way. Most of the schedules are 21 days, 7 days off, same once-a-day dosing, which is pretty nice.
Pills. And they're pills.
And they're pills, yes, thank you. So what do we know right now? So both of these drugs have been tested by themselves with dexamethasone, and they've had pretty good response rates. And I think Dr. Lee mentioned, the newer drugs have these amazing response rates. To have an oral drug have a response rate in the 40% range is pretty awesome. And this is a very cool slide here that I just wanted to show you. This is somebody getting mezigdomide. You can see that the response rate just with that drug alone is more than half the patients. But this is one of those proteins. This is ALOS. The myeloma cells are chock full, and after their 1 week on mezigdomide, it's gone. It is not there anymore. So that is pretty nice proof of principle here. So there's a bunch of studies going on. Mezigdomide, it partners well, and one of the very interesting things about mezigdomide, it seems to resensitize people to drugs that are thought to be like out of the race, can't use them anymore. And this has been found both with bortezomib and with carfilzomib. This is a little bit of a busy slide, but basically the news is right down in here. So these patients had all received bortezomib or carfilzomib before, and you can see really nice response rates, 60% over here with carfilzomib, almost 80% of people who've had carfilzomib previously, once they're on it with mezigdomide, respond again, which is pretty cool. So there's 2 trials that I want to just highlight here. The Excalibur trial, which was iberdomide in combination with daratumumab and dexamethasone. Now, we know that this has a positive trial. It met its endpoint, and so we are assuming that we're going to hear some news about iberdomide approval through the FDA, probably in this combination sometimes this summer. And in addition, at ASCO, just in a couple of weeks, we're going to hear from Dr. Richardson about the Successor trial, Successor 2. And so this is mezigdomide in that carfilzomib-dex combination that looks so great. And we all expect, this was accepted as a late-breaking abstract, meaning it's probably a big deal. So we're all expecting it to be very positive and to have some very nice results here. Now, there's many combinations that you might expect coming around with these drugs. It just makes sense that they would. And I think this is really going to be a fantastic option, particularly for patients who've already been through CAR T or other types of T-cell redirecting therapy, because it may sort of potentially even wake up the T cells. We're hoping that maybe that's an effect, but stay tuned. And again, I think this is just such a great option for patients. And we're going to hear from Beth a little bit about the side effects. And I'm just going to tell you very quickly a case. So this is a patient of mine, bunch of different therapies, who's currently on the Excalibur study. This is his band, the Sundogs. And they are a cover band for 80s hits. And so he was pretty upset when his myeloma came back 5 years after his transplant, thought, this is it. I can't do anything anymore. So he's on daratumumab with his iberdomide, daratumumab once a month, shot in, out. We took out the steroids a long time ago. This is actually him, the cool guy in the sunglasses. So with that, I'll turn it over to Beth.
Thank you so much. We can skip the discussion questions and go afterwards.
Yeah.
There's me again at the beginning of this slide. Who does that? So thank you, Dr. Callander, for so well describing how CELMoDs work. Again, we have some Cereblon blockage with the pomalidomide and lenalidomide, but I think that this represents another opportunity for patients to have a good option. The Excalibur studies and the Successor studies were also described by Dr. Callander previously. I have been on the Excalibur study. The cool thing about it is they have all these cohorts. They kept adding these cohorts, and I have a case study who's going to be on there as well. I do have just 2 more slides. I wanted to highlight for you what do we worry about as nurses if these drugs come to market, and have a discussion about that. So I mentioned all these cohorts, and here on the slide were the hematologic and non-hematologic treatment emergent events. And the cohort E, as you heard from Dr. Callander, was what we think might be approved. So Iber, Dex, Dara are It's Iber's the pills, and then the Dara you come in once a month with dexamethasone. You can see the neutropenia rates are pretty high, all grades 69%, but 53.8% in grade 4. So that's ANC less than 500. The good thing about it is we're smart nurses, right? You hold the dose, you reduce the dose, you give growth factor if you need to, and find the right dose. Most of the doublet studies with Iber-Dex, Mezi-Dex, they want to try to find that it's effective and safe. I think the doses in real world are going to be much lower after we start using this in clinical practice. Just like Dr. Lee said, he likes 1.9 instead of the 2.5. I think instead of 1 milligram of Iber, 0.75 might be a good dose. But again, I'm speculating and I'm guessing. Who knows? But anyhow, fatigue tends to be worse, less than what we would expect with pomalidomide, which is good, and it might be how the targeted effect of it is, and some diarrhea similar to what you would see. I'm not going to go on any of the cohorts. What about mezigdomide, Mezi-Dex? This is just the doublet. You also saw neutropenia 78% in all grades, with 54% grade 4. Same difference. We're going to hold the dose. We're going to reduce the dose. We didn't see any serious life-threatening infections, but you did see some infections such as pneumonia. As you heard Dr. Callander mention, this is a very potent drug. I see patients on the study that have suppressed kappa less than 0.7, lambda less than 0.7, similar to what you'd see in bispecific antibodies and CAR T-cell therapies, and it just speaks to the efficacy of the drug. I'm going to share with you my favorite case. This guy is amazing. He's 81-year-old IgG kappa myeloma, standard versus myeloma. So he was trucking along on Lendex until 2017. Then he had carfilzomib, pom, and Dex for a couple of years. Then he went on a clinical trial with Dara, Iber, and dexamethasone. Why? Because we had the Excalibur study, just like Dr. Callander probably had the Excalibur study at her institution. He had some grade 2 neutropenia, not too bad, and we reduced his dose within like 2 weeks because we could according to the protocol. And then eventually we got rid of the iberdomide because of the fact that he ended up having persistent neutropenia even on a very low dose. And we're like, let's just keep him on Dara. He has stayed on just Dara after having this dramatic response. We gave him IVIG on a monthly basis because his IgG levels are like 200 or 300 if we don't. But he had this dramatic effect with the Iber, and then now he's just on the Dara maintenance, comes in once a month, gets his Lorna-Doone, sees the nurses, gets his labs checks, and go home. And he's still in a complete remission and MRD negative. So that's all I have for you all. Great. And I don't know if we have time for discussion.
I think we have. Yeah, I think we're doing very well on time. So one thing I wanted to get back to, because I think that we maybe did not cover it enough. One was Dr. Lee's question was, how do you pick among the BCMA-targeted bispecifics? So you had that wonderful slide that sort of showed them all lined up. So as an institution, how do you do it? Or are there implications for the community? Is one better than another?
Yeah, are you talking about BCMA-targeted therapies in general?
Yeah, BCMA bispecific.
Oh, yes. So I think that there are a lot of similarities, but there are some subtle differences as well. So I think in terms of the over-response rate, we're seeing over-response rates at 60 to 70%. We're seeing good durability responses. There are some that are administered subcutaneously. So elranacimab and teclistamab are administered subcutaneously. Linvoseltamab is administered intravenously, and there can be pros and cons to both. So obviously sub-Q is just a shot, IVs, you have to insert an IV. Although I did want to highlight the median time to onset and resolution of CRS with IV bispecific tends to be quicker. So usually the general rule of thumb is that usually less than 1 day of onset and less than 1 day of resolution. So I think in terms of potentially monitoring patients, once they've gotten their initial step-up dosing, potentially a shorter time for monitoring with an IV bispecific versus subcutaneous bispecific. So these are some of the maybe subtle logistical considerations. I would say that it's hard to have all 3 bispecific T-cell antibodies on formulary probably at one institution. So ultimately choose the one that works best for your center, and whatever the patient has access to. Again, that's important to administer again whatever they have access to.
Can I just say, and Mary can speak to this very well because she's working on a PhD and she has a grant to increase access to rural communities for bispecific antibodies and other things. But sometimes if we're coordinating care, I have to pick up the phone and say, if they go back to this hospital 2 hours away, what do you have on? If you don't have elranatamab, I'm not going to give them elranatamab. They'll get teclistamab if that's what you have. So it's finding out what that patient has locally for sure.
Yeah. And I think there are logistical reasons maybe to choose one BCMA drug over another if you're at a place that hasn't started yet. Linvo being IV, it's kind of a long day, especially if the patient's getting prophylactic TOCI prior to that. But after that, you pretty much know they're not going to have an event, right? So if there's someone who it takes an hour for them to get to the office anyway, maybe once a week is better than multiple days in a row kind of having to stay close. If you're hospitalizing patients still, Elra has a shorter step-up dose, so maybe that's a reason to choose that versus not.
Well, and I just want to share with you one of my own personal experiences with trying to figure out how to pick is that if you are looking at the suggested dosing intervals for these particular BCMA bispecifics, there are some differences. But what happens in reality is I think most people start cutting back very quickly, whether it's a weekly, if the recommendation is weekly, we go to monthly pretty fast. And so we had done this economic analysis in our own hospitals thinking like, okay, are we going to maybe save money for the institution or for patients if we go with one that looks like it's dosed less frequently? But it was a washout. I mean, it really didn't make any difference, particularly if we're really spacing things out. So that's kind of how we were making a decision,
financially.
And again, if everybody's getting it once a month or once even every other month, it almost doesn't make any difference.
Yeah, it's really the step up is the thing you consider. Hospitalized for 7 days or 3 days.
Yeah, and I will mention that if you look across the board, all these bispecific T-cell antibodies can cause CRS. Numerically, there was a slightly lower rate of CRS with linvoseltamab, 45% versus TEC and ELRA. My theory is that if you have a really early onset of CRS, potentially after administration within 24 hours, all these bispecific T-cell antibodies, you get dexamethasone as a pre-med. So you're probably pre-medding against the CRS event. I think giving prophylactic tocilizumab will be the great equalizer probably with all these approaches. So I think, again, these are some of the subtle differences to consider.
Yeah. And I think to Dr. Lee's point that he made a while ago, it's just we really think it's very important for patients everywhere to have access to these drugs. So I don't think it really matters in some ways which you pick, and just saying what works better for you or what you have access to, or if you have a relationship with one distributor versus another. I think that's
or take Belantamab Mafodotin with bortezomib, and don't worry about the CRS.
Yeah, that's great.
You can make the argument that teclistamab and talquetamab are owned by the same company, so it's the same REMS. So sometimes when I'm speaking to a community practice and they haven't onboarded yet, you want patients to have both drugs available at some point in time, so it might make it easier.
Yeah. And I think right now we're also constrained by the label as well. Teclistamab in combination with daratumumab is approved for first relapse at this point, whereas ELRA and Linvo are approved for 4 prior lines of therapy. So I think this is a practical consideration as well when administering these agents.
So let me go back to the cell mods that we just discussed. Has everybody had a chance to get their feet a little wet with them? Mm-hmm. Yeah. So
I like Mezzi.
Yeah. No, they look great, and I guess. Let me ask your opinion because I think this is going to happen. We know that CAR Ts don't last forever. How do you think, or do you think there will be acceptance among patients to take a cell mod, say, post-CAR T?
Yeah, absolutely. We've had some resuscitations of relapse from Mezzi studies, and so this represents another option for patients. And it's so nice to go back to a pill after you've had cellular infusions, ongoing bispecific antibodies. Now you're saying I can just take a pill and a shot with something I'm comfortable with, and so that represents another opportunity. And absolutely, if we show them the data and suggest that it might be effective and the side effects are tolerable, then they're all for it, I think. It's that shared decision making.
And Natalie, I want to go to what you pointed out was the mechanism of action of cell mod. So they are, of course, have anti-myeloma activity, but they're also have some activity against rejuvenating T cells, the immune effector cells. And so, patients been on repeated T cell redirecting therapies, CAR T, bispecific, back and forth. Eventually, the T cells are petered out, right? So I think philosophically, I like to kind of have some type of intermediate regimen before going to another T cell redirecting therapy. I think cell mods represent a great option in that context. The other thing is that with mezigdomide in particular, there's been really, really great activity seen in what we call extramedullary myeloma. So these are patients with really high-risk soft tissue tumors. So this is myeloma that's escaped the bone marrow, essentially formed a tumor in the soft tissue. And I've had anecdotal experience for treating patients on Mezi studies that essentially unexpectedly seen really, really nice responses to EMD.
Yeah.
So I'm sure many of you know, or maybe in the audience you have not heard about this. There's a very large phase 3 trial going on post-autologous stem cell transplant of lenalidomide versus iberdomide. Any thoughts about that? And do you think there's going to be a clear winner? And do you think there's going to be maybe a better toxicity profile from iberdomide as time goes on, maybe with secondary malignancies, something like that?
I think there's less secondary primary malignancies as the initial safety signal we're seeing with the Iberlen maintenance study. So that represents something that might be very attractive to patients. And we have patients on that trial that tolerate it quite well against cytopenias up front when you're starting at the target dose. So we've had some dose reductions, but totally very well tolerated. And then the diarrhea that you get for the long-term len maintenance, we haven't been seeing that on iberdomide either. So that's another attractive option.
Yeah, I think that's a great study. I think my one concern about that study is I don't think we'll be doing autologous stem cell transplant for a bunch of patients in 5 to 10 years. So we'll have maybe other applications like iberdomide when that comes to play. But just because we're seeing such great activity with bispecifics, CAR-Ts and even ADCs up front.
Yeah, the CARTITUDE-6 study where we randomized to early stem cell transplant or CAR-T is done accruing. So in 20 years, we'll figure it out.
I know. Natalie's a transplanter, so I know that hurts you.
How many of you still referring your patients for an autologous stem cell transplant as far as their initial therapy? How many people do that?
Look at the hands. There's none. She's a transplanter. Yeah. No, we refer everybody, but it's definitely shared decision-making.
Just in the last couple of minutes, we have to be very provocative. Some people think CAR-T will be phased out and that it will all be bispecific engagers of various types. Any thoughts about that?
No. I don't know. We are still figuring it out, and hopefully through research we'll have better insights as to what is the right path to take.
Yeah, absolutely. I think the thing is one size doesn't fit all. I think there will be probably a debated topic. I think we debate it all the time. This will continue for many years to come. I think the nice thing is that I think we're going to make these therapies more accessible. So even with CAR-T, right? So I think we're figuring out that this can be delivered also in the community oncology setting. So I practice in the community oncology setting. I have colleagues within our research network that are administering CAR-T in their local outpatient, essentially oncology clinic setting. It's an operational sort of, there are a lot of operational considerations, but I think moving forward, a lot of companies developing CAR-T have this in mind. We didn't even talk about in vivo CAR-T, but that's kind of the next frontier with CAR-T really not requiring a cell therapy lab or manufacturing to deliver the CAR-T product. So I think these are all really exciting advancements in myeloma and cell therapy. So I think these will be exciting to see as they develop further.
Great.
And then I think just as the question that's out there, do you think we are ready to cure myeloma?
Oh, yeah. We saw in the CARTITUDE study that, and I always forget the statistic, after 5 years, 33% of patients are still MRD negative, no evidence of, and I think you're on an International Myeloma Working Group panel, Dr. Callander, to redefine the definition of cure in myeloma, which we didn't think was an opportunity 25 years ago when I started doing this. We were still giving melphalan and prednisone. Before thalidomide. So anyhow, that's great.
Yeah. All right. Well, thank you so much for attending and have a great rest of your afternoon.
Thank you, everyone.
Thank you.
Thank you.